Bismillahirrahmanirrahim. Welcome, my friends. Today we will begin our lecture about Crohn's disease, and in this part we will discuss the etiology, clinical picture, and investigations of Crohn's disease. Bismillahirrahmanirrahim. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. What is the etiology of Crohn's disease? What is the etiology of Crohn's disease? In fact, till now we don't know the exact etiology of Crohn's disease. As we know that if we know the etiology, you will have a treatment, okay? And this treatment will be curative. If you don't know the etiology, what we do is we look for the inflammatory cycles and we try to cut it or to dampen it or to make it weak so the manifestations of the disease will improve. As a definition, we can say that Crohn's disease is an inflammatory disorder characterized by an exaggerated immune response to the luminal microbiota and environmental influences in a genetically susceptible individual. That is to say that there must be three components for the occurrence or phenotypic expression of Crohn's disease. The first one is genetic background. The second thing is environmental insult. The third component is a change in the microbiota, so the immune system begins to attack the mucosa on which the microbiota live. The first component in the etiology of Crohn's disease is the genetics. Okay, we should know the following facts about genetics. Number one, genetics alone or the presence of genetic mutation alone don't mean phenotypic expression of the disease. So, when in mice, when they did deletion for the NOD2 CERD15, there was no inflammation in mice, okay? In patients with Crohn's disease, you will find that there is always mutation of the NOD gene. But in mice, when we did the same thing, inflammation did not occur. The second point is that the gene mutation in Crohn's disease is not peculiar to Crohn's disease, but it is also seen in other diseases like diabetes mellitus type 1, bronchial asthma, multiple sclerosis, and so on. So, the presence of genetic mutation does not mean phenotypic expression of Crohn's disease. The most common affected genes are NOD2, interleukin 23R, and FUT2, okay? Another point that may be Crohn's disease is a familial disorder. In fact, 10 to 30% of the patients have family history. And this family history is more obvious in Crohn's disease more than ulcerative colitis, okay? And it is more common in the Jews more than the non-Jews, and in the white more than the black and the Hispanics, okay? If we look to this table, which was published in the gastroenterology clinics, okay, we know that there are serious complications for Crohn's disease. The first one is inflammation. The second one is stricture formation. The third one is penetration, which means fistula formation or abscess formation. All these points will lead to surgery, and we know that anti-TNF is a treatment used for Crohn's disease, but sometimes the patient loses the response for it. Okay, when we look to the location, you will find that most patients who have Crohn's colitis have HLA loci DRB1. Okay, If we look for the patient who have structuring disease, you will find that most of them have NOD2 mutation, okay? If we look for the patient who have extra-intestinal manifestation, for example, affecting the eye, it is they will have mutation in the HLA loci, okay? If we look for the need of the surgery, okay, you will find that it is associated with the NOD2 mutation. The poor response for the anti-TNF like infliximab and adalimumab and so on, you will find that it is associated with mutation in the interleukin 23, okay? But the good response, it is associated with mutation in the TNF SF15 gene. So this table shows the relationship between the presence of the gene mutation and the pattern of the disease and the response to the therapy. If you read in the literature, you will find that the etiology of Crohn's disease and ulcerative colitis is the same. Okay, we have protective factors and we have risk factors. Okay, the protective factors are vitamin D, high fiber diet, Helicobacter pylori, helminths, okay, breastfeeding, okay. But if we look for the risk factors, you will find that they are the oral contraceptive pills, gastrointestinal infections, high carbohydrate or fat diet, urban setting, air pollution, and antibiotics. That's very important, okay? In Crohn's disease, you will find that smoking is beneficial. Meanwhile, in ulcerative colitis, in Crohn's disease, you will find that smoking is a risk factor, which increases the incidence of the complication and the post-operative recurrence of the disease. Meanwhile, in ulcerative colitis, you will find that smoking is protective. This is very important. We said, we have said that the occurrence of Crohn's disease needs genetic background, but it is not sufficient alone for phenotypic expression. There must be an environmental insult, okay? If we look to most studies, we can find the following points which could be considered as environmental insult or they are protective, okay? If we look for smoking, for example, smoking in patients with ulcerative colitis is safe, and the more the number of the packs smoking in ulcerative colitis, the more the response or the more the improvement on the disease. In Crohn's disease, you will find that smoking is very harmful. It is like putting a fire on the patient. It increases the activity of Crohn's disease and it increases also the incidence of post-operative surgical recurrence. So, in the guidelines, you will find that any patient who will undergo surgery, he must stop smoking. He must stop smoking. Appendectomy. Appendectomy, they found that it is more associated with the occurrence of Crohn's disease, okay? But in fact, some people say that most patients who underwent appendectomy, they were from the start Crohn's disease, okay? They were from the start Crohn's disease, okay? They found that in the liability or the liability of finding a perforated appendix during operation is more associated with increased risk of occurrence of Crohn's disease. The chronic intake of NSAIDs is also more associated with the occurrence of Crohn's disease. They found that antibiotics abuse in the first year of life in babies is also more associated with the occurrence of Crohn's disease. The outdoor occupations, okay, also they found that the outdoor occupations are more associated with decreased incidence of chronic disease. Also, we have said the diet, breastfeeding, and sleep duration. They found that the people who have deprivation from sleep have more incidence of occurrence of Crohn's disease. So, it is very important to give advice for your patient to have a good sleep. Okay? Psychological factors. There are studies which said that they are more associated with the occurrence of Crohn's disease, and the other studies said that there is no relation between the psychological factors and the occurrence of chronic disease, but the presence of stress in a patient with diagnosed or proven Crohn's disease is more associated with exacerbation of the symptoms. Okay. Also, in this table, it shows the odds ratio between the environmental factors and the occurrence of the disease. The odds ratio for smoking and Crohn's disease is 1.7. Okay. Tonsillectomy, appendectomy, they are risk factors for the occurrence of the disease. Tea consumption is associated with decreased risk. High levels of folate is associated with decreased risk. Vitamin D, the same. They found also that, but this is in ulcerative colitis, but in Crohn's disease, the proven to have decreased risk with Crohn's disease is the high levels of vitamin D and the gastric H. pylori infection. Okay, they found that the third component for the occurrence of Crohn's disease is a change in the microbiota, in which there is loss of the oral tolerance of the mucosal system to the microbiota. We know that the GIT is full of millions of microbiota, and we know that we can classify microbiota into beneficial microbiota and harmful microbiota. These microbiota, they aid in digestion. They are responsible for the generation of the short-chain fatty acids from the carbohydrates, which are very important for nourishment of the colon cells. Okay, they found that in patients with inflammatory bowel disease, there is a change in the microbiota in which there is increase in the bacteria which are causing inflammation, okay, like the proteobacteria and actinobacteria. Meanwhile, the beneficial bacteria, they are decreasing, okay, like the bacteroids and firmicutes and actinobacteria like bifidobacterium. Okay, so you will find that the beneficial bacteria are decreasing, but the harmful bacteria are increasing, so the immune system will consider them as a foe and will try to damage them, but because these bacteria are on the mucosal surface, he will attack the mucosa. If we look for the epidemiology of the Crohn's disease, you will find that the incidence of Crohn's disease is increasing all over the world. And this map, it shows the distribution of the disease. The highest prevalence, you will find that it is present in the Americas, okay? But if we look for the South America, you will find that it have intermediate occurrence and it has also lowest recurrence. In Africa, it is uncharted, okay? We don't know till now the etiology of Crohn's disease, but they found that it is more occurring, or it is more, the occurrence of Crohn's disease is more in the developed countries more than in the developing countries, in the urban more than in the rural areas, and they found that the Jews have sevenfold incidence of Crohn's disease is slightly common in females more than males. If we look for the age, you will find that there are two peaks for the occurrence of Crohn's disease. The first peak when the age is between 15 and 30, okay? And the second peak, although it is rare, between the age of 50 and 60 years old, okay? What is the definition of Crohn's disease? We should know that in 1932, Crohn's disease was described by Crohn and colleagues. The best definition for Crohn's disease is a chronic, progressive, destructive disease. Again, chronic, progressive, destructive disease. It may affect any part of the GIT from the mouth to the anus, but it is not a continuous disease. There are normal areas between the affected areas, so we call it skip areas. And at the same time, it can affect all the layers of the GIT from the mucosa till the serosa, but it occurs in a focal distribution or a patchy distribution. It is characteristic. It is characteristic. We should know that Crohn's disease is more associated with complications like strictures, fistulae, abscesses, extra-intestinal manifestations, surgery, and disability. This slide is the key to understanding Crohn's disease. If we understand it, you will find that it is very easy to study Crohn's disease. Crohn's disease, okay, it causes inflammation. This inflammation clinically causes pain, okay? This inflammation causes stricture because it heals by fibrosis. This stricture may cause GIT obstruction. Sometimes the inflammation it extends to the surrounding organ and false tracts are formed which are called fistulae. These fistulae will cause discharge. If we open to a cavity, abscesses will form. It will cause sepsis, okay? And it is associated also with extra-intestinal manifestation, okay? I will have inflammation, stricture, fistula, abscesses, EIM, okay? Clinically, we will have pain and diarrhea, obstruction, discharge perianal or from any fistula, okay, sepsis. Because we don't have a curative treatment, most of the patient will require surgery, and this surgery will be repeated as we see in this curve. As a result, disability will occur, and some people who undergo multiple resections of the intestine will have short bowel syndrome and death unless intestinal transplantation done. In the recent years, with the introduction and the discovery of the biological therapy, we could cut or dampen the inflammatory cycles in Crohn's disease. They don't treat the etiology. What they do is that they dampen or weaken or decreasing the intensity of inflammation. So most of these symptoms and signs will improve. So the patient will be happy. If we understand this slide, we will understand also multiple slides later on, especially in the assessment of the disease. What is about the natural history of the disease? We should know that Crohn's disease is a dynamic disease in which there are periods of remission and there are periods of activity. If we look to Lehman score here, you will find that after the occurrence of the disease, okay, and the diagnosis, most patients will proceed to the occurrence of stricture, and strictures, they increase the incidence of fistulae and abscess formation. They will need surgery, okay, and after surgery, there is recurrence of the disease and restructuring again of the GIT. This is the sad story of patients with Crohn's disease. But the presence of biological therapy now will change this pattern, okay? Will it change this pattern? But the problem that in many patients with Crohn's disease, when we begin the biological therapy with them, we begin the biological therapy late after occurrence of the complication. So the effect of the biological therapy will not be as expected. Okay, inflammation, it will proceed to penetration, fibrosing, and stricturing. So we can have the following pattern of the disease. The first one is aggressive fistulizing disease, indolent cicatrizing disease, or neither fistula or cicatrization. Okay. Also, the presence of fistula and stricture may occur at the same time. Okay, because if we have a stricture, before it there will be increased pressure inside the lumen, which will facilitate the occurrence of fistula. Fistulae are the most disgusting and annoying complication for the patient because his body gets out discharges from abnormal areas. Okay, when they studied the fistula, okay, which may occur in the perianal region, and you will find that the patient buttocks will have multiple openings discharging pus, awful pus, okay, perianal disease. This is called perianal disease, complex perianal disease, okay. The fistulae may occur between the colon and the duodenum, the colon and the stomach, between the small intestine and the colon, okay, between the lobes of the small intestine themselves, okay, and sometimes between the colon or the intestine and the skin, which is called enterocutaneous fistula. Okay. In females, fistulae may occur between the rectum and the vagina, okay, rectovaginal fistula, or between the rectum and the urinary bladder, which is called the rectovesical fistulae. And so the patient will have polymicrobial UTI. The female will have awful discharge from the vagina, and so on. Fistulae are annoying for the patient psychologically, socially, and also they are annoying for most of the physicians because they are refractory to the conventional therapy. They found that there is association between some genes and some antibodies and fistulae. They found that most fistulae are associated with NOD2 variants. Okay, they are more common if the patient have antibodies like the positive anti-Saccharomyces cerevisiae antibodies ASCA, positive anti-flagellin, okay, positive anti-outer membrane porin C of the E. coli, which is called anti-OMBC, okay. If these antibodies are positive, they are more associated with the occurrence of fistulae, okay. They found that if we have a proximal disease of the small intestine, it is more associated with fistulae than the distal disease. During endoscopy, if you find deep ulcers, they are more associated with fistulae formation and aggressive disease. If we look for the NOD2 mutation, because they are commonly associated with fistulae formation, you will find that if we have one gene mutation, it is associated with 8% increase in the risk of complication. If we have two gene mutation, you will find that we have 41 increased risk of complication and 58% increased risk of surgery. This is a nice table which is present in the Canadian Association Gastroenterology Clinical Practice Guidelines for Management of Luminal Crohn's Disease. They put certain criteria. When you find it, you will have a patient with aggressive disease, a patient with complicating disease with fistulae or stricturing or so on, increased liability for surgery and disability, and also recurrence of the disease after surgery. And nowadays also we can say it is more associated with decreased response to biological therapy. Clinically, finding a younger patient who is smoking and have longing disease duration. Okay. Also, the presence of fistulizing perianal disease is more associated with aggressive disease and the previous resection. The disease location is very important. The disease extent, the more the disease extends, the more the aggressiveness of the disease. Low hemoglobin, low albumin, high CRP, high fecal calprotectin is more associated with relapse, surgery, complication. The presence of deep ulceration in endoscopies are also associated with aggressive disease. Now we come to what is the location of the disease. We have said that Crohn's disease, it may affect any part of the GIT from the mouth to the anus. Unlike ulcerative colitis, which is confined to the colon only. Okay, we have a nice classification which is called Monterial classification. We have a nice classification which is called Monterial classification. In this classification, he put the letter L to account for location. Okay, so L1, the disease is confined to the terminal ileum. Okay, in L2, it is confined to the colon. In L3, it affects the intestine and the colon at the same time. L4, it will extend to the upper GIT, okay, including the stomach and the duodenum, jejunum, and so on. And L4 plus L3 if we have combined ileocolic plus upper GIT. This is Monterial classification, and this is the location component. Crohn's disease, in 50% of the patient, you will find that generally speaking, that Crohn's disease is confined to the ileocecal region. In 50% of the patient, you will find that the disease is confined to the ileocecal region or the terminal ileum. Okay? Sometimes you can find the patient with Crohn's disease without ileal affection. In a nice study, they found that 25% of the patient, whatever the location of intestinal affection, they will have perianal disease. Okay? 1% of the patient will have upper GIT Crohn's. 30% of the patient will have isolated Crohn's colitis. 30% of the patient will have isolated small bowel Crohn's disease, and 35% of the patient will have ileocolic disease, that is to say affection of the terminal ileum and the proximal ascending colon. This is the role of 3, 1/3, 1/3, 1/3. Okay? In 85% of the patient, Crohn's disease is stable in the location. Okay? The patient had ileocecal Crohn's disease, he will continue to having ileocecal disease. But in 15% of the patient, it is extending. It may extend proximally to the jejunum or extend distally to the rectum and sigmoid colon and so on. So, Crohn's disease, it may affect any part of the GIT from the mouth to the anus. It is commonly affecting the terminal ileum and the cecum, and this will be stable in 85% of the patient, but in 15% of the patient it may extend to other parts. If we find ileocecal Crohn's disease, it will be easy for us to diagnose Crohn's disease. But the other part is, it will be difficult. Why? Because if we have isolated Crohn's colitis, we will say, is it UC or Crohn's disease? It will be a dilemma. Sometimes we call it indeterminate colitis. In patients with upper GIT manifestation, they found that they will have at a certain point of time ileocecal disease, but it may occur in the GIT, in the upper GIT before the ileocecal valve. So the diagnosis will be challenging. If you have a case with ileocecal Crohn's disease in diagnosis, you will be lucky. But in the other parts, they will need more effort and they will be challenging. Monterial classification has classified the disease according to the age, according to the location, and according to the behavior. According to the disease, in the A3, which is age 3, it will be above 40. Generally speaking, any patient under 40, he will have aggressive disease. Okay? The location of the disease, L1, L2, L3, and L4, we have said before. The behavior, okay? B1, non-structuring, non-penetrating. B2, structuring. B3, penetrating. B, account only for the presence of perianal disease. Okay? This is seen also in this diagram. What is the clinical picture of Crohn's disease? The problem we are always facing that the patient comes to you in the gastroenterology clinic late. And sometimes the symptoms of Crohn's disease, you can't differentiate it from other diseases. Especially celiac, for example. The symptoms of Crohn's disease are not specific for Crohn's disease. So, as we have said before in UC, we will say it again in Crohn's disease. The diagnosis of Crohn's disease is a constellation of clinical, radiological, endoscopic, and histological features in which we will find focal asymmetric and transmural granulomatous inflammation of the luminal tract. Another point is that there is no correlation between the symptoms and the histological activity. And we have a lot of patients with remission and also they have the same symptoms. This is very important. So the symptoms may be a bad clue for you and we should not depend on it. We should depend on other items for finding remission like endoscopy and biomarkers like calprotectin and so on. Okay? The manifestations of Crohn's disease will differ according to which location is affected. In general, most patients with Crohn's disease will have abdominal pain, diarrhea, fatigue, weight loss, fever, gross failure in children, anemia, recurrent fistula, extra-intestinal manifestations. Okay? If we do the fecal occult blood test, you will find that it is positive in 50% of the patient, even if they don't have overt rectal bleeding. Abdominal pain is common in patients with Crohn's disease. It is more common than UC patient, and it is common to find the pain after meals, especially in the right iliac fossa. It may be due to the inflammation, obstruction, abscess formation, and so on. There is non-blood diarrhea because if the terminal ileum is heavily affected, there will be no absorption of the bile acids and there will be bile acid overflow diarrhea. Maybe we have fever, we have fatigue due to the vitamin deficiency. Most patients with ileocecal Crohn's disease will have generally abdominal pain, and sometimes this pain is confined to the right iliac region, so it will be mistaken for appendicitis. As a result, you will find that many patients underwent appendectomy but with wrong diagnosis, and during the operation they were found to have Crohn's disease. Of course, the mucosal inflammation, it will cause malabsorption with diarrhea. If a stricture is formed in the region of the iliac region, there will be backwash, there will be increased pressure here, and there will be partial intestinal obstruction. Sometimes when the disease extends to the serosa, maybe we find the right iliac mass. In Crohn's colitis patient in which the colon is affected, especially the isolated type, you will find that the rectum during endoscopy is spared. But stop, we have said before, that if the mucosa looks normal during endoscopy, that does not mean that it is devoid of inflammation. We should take biopsies because biopsies may show active inflammation. But generally during endoscopy, they will have also blood diarrhea. They will have abdominal pain more than you see. You will find that the inflammation, in contrast to you see, it will begin in the cecum and spreads distally towards the rectum, and the rectum spreading is common. And also you will find that there are escape areas like these whitish parts. Okay. In UC, you will find that the inflammation, it begins in the rectum and spreads proximally in a continuous pattern with sharp demarcation between the erythematous area and the normal area. And we have said before that the rectal spelling in patients with UC is seen with rectal therapies or in patients with primary sclerosing cholangitis or 30% of the children patient. If we have upper GIT Crohn's disease, whether it is associated with ileocecal manifestation or not, they will have simply gastritis, ulcers, okay? They will have dyspepsia, and if these ulcers heal by fibrous tissue, they will obstruct the pyloric region. As a result, they will have gastric outlet obstruction. If it occurs in the esophagus, the inflammation will cause duodenophagia. There will be strictures which causes dysphagia and food impaction. Okay. In the mouth, you will find that most of these patients will have recurrent abscess ulcers, and this female patient, she has dysphagia. Inflammation means pain. Means pain. Means lack of absorption. Okay, it will heal by fibrosis, which leads to stricture formation. A stricture in a luminal organ will lead to obstruction, small intestinal obstruction here or gastric outlet obstruction. In the esophagus, it will cause food impaction and dysphagia. This is MRI of a patient. Here you find that there is affection of the ileocecal region. You will find that the mucosa is thickened and enhanced. Okay, there is here a stricture, and before the stricture there is dilatation, as we seen here. And here you will find that there is multiple fistulae. Now we come to fistula formation, the most annoying symptom for the patient and the physician. How is the formation, or in another words, how do fistula form? Simply, the transmural inflammation and the presence of also of a stricture, it leads to tissue destruction and back pressure, which leads to sinus formation. Opening into epithelial lining organ leads to fistula formation. The fistula, it may occur within the GIT itself, between the intestine and the intestine, anterior, but we will call it enteric fistula. Between the intestine and the colon, enterocolic, okay? Between the colon parts themselves here, and it is common between the sigmoid colon and the left and the descending colon, we will call it colocolonic. Between the colon and the duodenum, coloduodenal. Between the colon and the stomach, cologastric fistula, okay? It may occur between the ileum here and the retroperitoneal structure. And here, when fistula occurs, it leads to discharge of fluid to the peritoneal cavity or the retroperitoneal spaces. So there will be abscess formation or foligmen formation, which compresses the right ureter here in this region, and the patient will have right hydronephrosis. This is very important. The fistula, it may also form between the intestine and the urinary bladder, so it will be enterovesical fistula or colovesical fistula, okay, whatever. Intestinal fluids or intestinal secretions, which are fluid of bacteria, will go to the urinary bladder, which causes polymicrobial UTI, okay. In patients who underwent hysterectomy, there will be formation of fistulae between the rectum and the vagina, which we will call it rectovaginal fistulae. Okay, so the patient will have dyspareunia, awful vaginal discharge. Okay, sometimes the fistula also it occurs between the intestine or the colon and the skin. We will call it enterocutaneous or enterocolic fistula, and he will have continuous discharge from the skin. The most common fistula is the perianal disease or perianal fistulae. They occur in 25% of the patients. Okay, they are very common in patients with Crohn's disease, and so they are put in a special look in the behavior in the Ontario classification. Stricture is a sign of long-standing disease. Commonly, we can find it in any part, especially the terminal ileum, and it is common in the anastomotic sites. Okay, there are three types of the stricture. In the first stage, you will call it inflammatory, in which the inflammation it occurs in all the layers of the terminal ileum. So the wall will be thickened, okay, as we see, and of course the lumen will be narrowed. In X-ray with contrast or CT with contrast, you will find that the terminal ileum is seen, the intestine is seen, and the terminal ileum is seen as a string, cotton string, and they call it strain sign. They call it strain sign. Okay? By the time this inflammation will heal by fibrosis, so we will have a fibrotic stricture, and we know that most of fibrotic stricture will have dilatation before them. Sometimes this stricture is malignant. Can we differentiate them? It is very difficult topic, and the multiple biopsies and even excision is needed to distinguish the three types. Intra-abdominal abscess, the inflammation of the serosa or fistulae, which occurs into the peritoneum, leads to abscess formation. So the patient will have spiking fever and abdominal tenderness and peritonitis, and it is emergency which needs antibiotic therapy plus surgery or radiological intervention nowadays. Perianal disease. Perianal disease is very important point in Crohn's disease. The map of treatment of any patient with chronic disease will differ if he has perianal disease or not. If the patient has perianal disease, we will have another route map, and if he does not have perianal disease, he will have another plan of treatment. So it is very important. We have said that the perianal disease is present in 25% of the patient. What is the time of occurrence? It may occur at the same time of occurrence of intestinal disease, but they found that in most patients, the perianal disease or fistulae they form, and later on the intestinal manifestation are observed. This is a problem. If you find perianal disease with intestinal manifestations from the start, it is easy to diagnose Crohn's disease. But sometimes the surgeon refers a patient with complex perianal fistula for you. You do ileocolonoscopy and you took biopsies. Normal. You will say to him, no, this is not Crohn's disease. But in fact, it is the first step in the disease. Okay? The perianal disease, it includes anal fissure, ulcerated edematous piles, ulcers, which are called coagating ulcers, and aggressive ulcerations. There are secondary lesions, like maybe there is a stricture in the rectum, maybe there is perianal abscess, skin tags, whatever, fistulae, and the fistulae may extend to other parts. When we discuss perianal fistula, as a gastroenterologist, you should have an answer for this question. Is it simple fistula or complex? Because the treatment is different. Okay? The AGA, American Gastroenterology Association, have classified these fistulae into two types. Simple fistula, in which the internal opening is present below the dentate line and it is close to the muscle, and the opening is close to the anus. Okay? And the high fistula, which is called complex fistula, in which the internal opening it will be above the dentate line. It may be intrasphincteric or transsphincteric, and it may have an opening away from the anus or multiple openings away from the anus. So the question when you have perianal disease and fistula, is it simple fistula or complex fistula? Simple fistula, they are located distant to the dentate line, and they are primary in the anal sphincter region with single tract. This one, like this one. Okay. The complex fistula, it may be transsphincteric, suprasphincteric, and intrasphincteric. Okay, and may have multiple tracts. Okay. Of course, the best examination for fistula it is done by the surgeon under general anesthesia, so he can examine the tract and the presence of abscess or not. Okay. In this diagram, this is perianal fistula. This one is transsphincteric one. This one is extra-sphincteric, as you see. And this is called suprasphincteric one, and this is called intrasphincteric one. They are different types of the complex fistula. But for you as a gastroenterologist, you have one question only. Is it simple like this, or the others we call it complex fistula? Okay? What is the problem of complex perianal disease? Really, the patient will have pain, discharge, embracing discharge, and significant reduction in quality of his life. He will have impaired sexual and psychological function. If we look for these buttocks, there are multiple openings which are characteristic of complex fistula, in which there is continuous output of fecal matter. Okay, it resembles the watering can, this one which is used for irrigating plants, so it is called watering can anus. The patient will always be impressed, confused. He will get out from social activities because of the bad odor. He has to change his diapers continuously and so on. This is a big problem we face in patients with complex perianal disease. Awful, always awful discharge, embarrassment, watering can anus. In the first year, as we see here, he has 6 friends. In the second year, he will have 4 friends. 2 will get away from him due to the awful discharge. In the third year, he will have 2 friends, and for the fourth year, he will be alone with his dog. So, complex fistula is associated with decreased number of friends, fear of people, being alone, and psychosis. So, if you find a complex perianal disease from the start, you will change your plan of treatment. What are the investigations done for patients with Crohn's disease? Laboratory investigations. There is no test that is diagnostic for Crohn's disease. And most patients with mild disease will have normal investigation. But abnormal investigation will be found in patients with moderate to severe disease. Of course, there is destruction of the mucosa, there will be anemia, increase in the WBCs, increase in the platelets, increase in the inflammatory markers like ESR, C-reactive protein, hypoalbuminemia, protein loss enteropathy, of course, will be present. Due to ileal affection, there will be decreased absorption of vitamin B12 and maybe deficiency of the folic acid due to bacterial overgrowth or ileal resection. Due to the ileal disease, there will be no absorption of the bile acid, so there will be decreased the calcium and the magnesium. Of course, we should do stool analysis to exclude any infection, especially strongyloidosis, okay? We should also exclude Clostridium difficile in patients with Crohn's colitis and so on. The antibodies, they are not routinely done. They are not routinely done. They are expensive, but their presence, as we have said before, that they are associated with more aggressive disease. The recent test which is done nowadays is the fecal calprotectin or lactoferrin because we can use them to differentiate the disease from irritable bowel disease. We can monitor by them the activity of the disease and the liability of relapse after remission. In fecal calprotectin, in this slide, before measuring the fecal calprotectin, you have to exclude any cells intake or any infection, okay? If we find that it is high, more than 25, I'm sorry, 250, it is more associated with inflammation and the liability of irritable bowel disease is less, okay? What are the imaging modalities used in the diagnosis of Crohn's disease? We have the conventional X-ray, we have abdominal CT with contrast, we have CT enterography, we have MRI enterography, we have MRI pelvis, and we have small bowel ultrasonography, SUS. So there are multiple modalities, and always in any disease, when you find that there are multiple types of imaging used, there are no specific one for the disease, or there are multiple variations of the disease. No imaging is diagnostic for Crohn's disease. The role of X-ray in patients with Crohn's disease is to detect megacolon perforation. Okay, we can do CT abdomen with contrast. We can do CT enterography as we have said before, and also there is a new investigation which is called dynamic Vista, which is under research. If we look to this imaging here, you will find that the terminal ileum, it looks like a cotton rope or a cotton strand. So it is called the strain sign, and sometimes it is due to just a spasm of the ileum. When the radiologist gives Buscopan for the patient, it reverses, okay? So in radiology, it means spasm or restriction. Here we see this yellowish tissue. It is fat, and it is called creeping fat, which is more associated with increased inflammation. Here, this is the comb sign. It is like the comb which we use it for hair dressing. Okay, this is they are dilated vasa recta. It is very obvious here in this CT. Okay. Also, we can see detect fistulae. This is enterocutaneous fistula. Okay. Here there is fistula between, this is the colon, okay, and this is the small intestine, okay. This is the ileum, okay, this is the ileum, and there is fistula between the terminal ileum and the colon. Here we can find air fluid level, which is fixed here. This is called abscess, okay. These findings are easily taken by CT. We have a new modality which is called CT enterography or CT enteroclysis, okay. If the patient drinks the contrast, it is called CT enterography, and if you put a nasogastric tube and give contrast through it to the duodenum, it is called CT enteroclysis. Okay? CT enterography is the best radiological modality for number one, diagnosis of the disease, number two, extension of the disease, number three, assessment of the activity, number four, the occurrence of remission, number five, the recurrence of the disease. The drawback, it is associated with excessive radiation exposure. So generally, when we have a patient with Crohn's disease, number one, do C2 enterography for him to assess, to diagnose, know the location of the disease, the extent, the severity, and the map of the disease. Okay? And if it is associated with complication like perianal disease, stricturing, fistulae, abscess, and so on, then during follow-up with treatment, we can do MRI enterography because it is not associated with radiation. Okay? Why we proceed to imaging? Because if we suppose that we have a patient with Crohn's disease which is confined to the terminal ileum, but in the proximal part of the terminal ileum, not the distal part. You know that during ileocolonoscopy, you can examine just 10 centimeters or 20 centimeters from the ileum. You will find them free. Here, you will find that the inflammation is out of the reach of the scope. So, imaging is complementary for endoscopy. Okay? MRI is very useful, but we know that its drawback that it takes a lot of time and it is very expensive. Pelvic MRI, fistulogram, and EOS, they are mandatory in patients with perianal disease to know, number one, what is the type of the perianal fistula, simple or complex, if there is perianal fistula, if there is perianal abscess or not, and also what is the extent of the rectal disease. A new modality is used nowadays in expert centers. It is called small bowel ultrasonography, and the research is continuing on it because it is non-invasive and easily to be done. Here we find this is an X-ray, this is CT, and here you can see in this GIT mucosa that there is increased thickness of the mucosa. This is a terminal ileum. You can find that there is increased mucosa, thickened mucosa more than 4 millimeters. This is MRI of the abdomen, MRI enterography, okay, and this is a small bowel ultrasonography. Here there is MRI enterography. You will find that the disease is restricted to the terminal ileum. Here is the thickening of the mucosa. And also this is complementary small bowel ultrasonography. This is MRI pelvis. And as you see that the arrows are pointing to the fistulae, okay? Here, this is fistula, and this is fistula, okay, this is fistula. So MRI of the pelvis is mandatory in patients with MRI disease to know the type and the complication of perianal disease. What are the endoscopies which can be done in patients with Crohn's disease? The conventional ileocolonoscopy, we may need upper endoscopy, EGD, we may need enteroscopy, and we may need video capsule. Ileocolonoscopy is the golden standard endoscopy in patients with Crohn's disease because we have said before that 50% of the patient will have disease confined to the ileocecal region, but 20% of the cases will be beyond the colonoscope. Okay, so imaging will be complementary. We should take biopsies for the normal and the abnormal mucosa because the normal mucosa during endoscopy may have histological activity. Endoscopy is very important for diagnosis, assessment of the severity, monitoring of the response to treatment, and detection of complication. Biopsies are mandatory from normal and abnormal mucosa. As we see here, we can see abscess ulcers overlying the lymph follicles, like here. We can see cobblestone. We can see longitudinal ulcers with pus and the granularity, thickening of the mucosa, decreased lumen diameter, and so on. Okay, biopsies are very important. They will show focal or patchy inflammation. Endoscopies is very important tool for us because using endoscopy, there are scores by which we can classify the activity of the disease, like endoscopic index of severity, This is commonly used in guidelines, and also the simple endoscopic score for Crohn's disease. This is very important for us, simple endoscopic score, because the simple endoscopic score is commonly also used in the guidelines for assessment of the disease. We have the Redgert's score, which is used post-operative to assess the recurrence of the disease after ileal resection. Upper endoscopy, it should be done only if there is dyspepsia or there are symptoms which may indicate the presence of upper GIT infection. Okay? Enteroscopy, it can be done if you are suspecting the presence of Crohn's disease and you did ileoconoscopy and you did not find something, because the inflammation here, it will be out of the scope of the colonoscope. We may proceed to enteroscope or CT enterography, but we don't prefer enteroscopy because it is very expensive and it is present in centers and time consuming. What is about videocapsule endoscopy? Videocapsule is simple endoscopy and it is not harmful for the patient. Okay, and it can assess whole GIT, unlike ileoconoscopy. It may assess from the mouth downwards and so on. It may assess from, from the stomach and so on. But the problems with video capsule is, number one, it has low specificity, 50%. The other point is the risk of impaction. In fact, the risk of impaction of capsule in the small intestine is low, but if it occurred, it may need extraction of the capsule by enteroscopy or commonly used surgery. So most patients are afraid. So some guidelines said, if you have symptoms of possible obstruction like nausea, vomiting in a patient with Crohn's disease, and there is high liability for the presence of structural and partial intestinal obstruction, avoid video capsule. Okay? Or if you can use what is called patency capsule. Patency capsule is a capsule which disintegrates after a certain point of time. So if it is impacted, it will disintegrate and so it will not harm the patient. Okay? The role of EUS is used till now. EUS is used only for assessment of the perianal disease. These photos are taken from video capsule, and you can see here edema, erythema, and ulcerations, and of course you will find that there is some sort of stenosis here. This slide it discusses the small bowel assessment in IBD. It is present in the Monday night IBD. If I suspect Crohn's disease, okay, I should do colonoscopy with terminal ileum TI examination, and we should not do EGD or enteroscopy except if we have upper GIT manifestations. Okay, so suppose in the patient I did colonoscopy and terminal ileum examination and I did not find data, I will proceed, because I am thinking of Crohn's disease, to upper GIT, because we have said that the manifestation may occur before the terminal ileum, and enteroscopy. Okay, if we find them negative, we can proceed for cross-sectional imaging like CT enterography. If you are afraid from radiation, you may proceed to MRI or ultrasonography, small bowel. If MRI is negative, here we can proceed to video capsule endoscopy and so on. About the pathology, of course, in the early finding, we will find abscess ulcers, the granuloma. But the granuloma, it should be, number one, differentiated from the TB. This is very important because many cases which have ileocecal disease, they were found to have TB. If you are suspecting TB and it is Crohn's disease and you give anti-tuberculous treatment, okay, what will occur? Nothing. There will be progression of the disease. Okay. But if we have Crohn's disease and we have given anti-TNF and exactly it is TB, there will be flare of TB. So we should be cautious. Of course, the granuloma, it may be present in any part of the GIT in any layer, and by the conventional biopsies, they are present in 30% of the patient. They need excision biopsy. Okay. طبعا in the late pathology you will find that there are ulcers, submucosal, fistulae formation, sinusitis, transmural inflammation, fat wrapping we have said before, or creeping. Now we come to another section about the extra-intestinal manifestation. If we look to this diagram, which is present in the Lancet, okay, Crohn's disease is associated with multiple diseases, okay? And if we remember, we have said that genes which are present in patients with Crohn's disease, they may be also present in other diseases, okay? It is associated with multiple sclerosis, in the eye, iritis, uveitis, sensory neuronal hearing loss, abscess ulcers in the mouth, autoimmune thyroiditis, bronchial asthma, vasculitis, myocarditis, autoimmune hepatitis, ITB, celiac disease, autoimmune pancreatitis, nephritis, urophysiasis, axial arthropathy, psoriasis, and so on, osteoporosis, polyarticular arthritis, polyarticular arthritis, pyoderma gangrenosum, erythema nodosum here, as we see, primary sclerosing cholangitis. These are the most common diseases associated with Crohn's disease. The association of extra-intestinal manifestation is more common in Crohn's disease patient more than UC patient, and they may occur at the same time with the disease, before or after the disease. And the general principle we have, if you have extra-intestinal manifestation at the same time with active Crohn's disease, just the treatment of active Crohn's disease is sufficient for treatment. Abscess ulcers, they are present in 10% of the patient. We may have angular colitis due to vitamin deficiency, okay? Erythema nodosum, which occurs on the extensor surfaces of the limbs, okay? And it paralyzes the Crohn's disease activity. So just giving treatment for Crohn's disease will improve spontaneously. We may have side effects, of course, from the drugs like steroids and sulfasalazine. Metastatic Crohn's disease. Metastatic Crohn's disease, if we look to the skin, you will find that there are lesions. When they were excised and the histopathology revealed that they are metastatic Crohn's disease, it is inflammation of the skin removed from the GIT, but histologically typical too is present in the intestine. It may be present behind the ears, in the perineum, in the feet, in the penis, in the vulva. Okay. Another problem we have is this called oral biostomatitis or bioderma vegetans, okay, as we see in this picture, which are pustular eruptions of the oral mucosa. Sometimes we find psoriasis in association with Crohn's disease. This is bioderma gangrenosum. It may occur in parallel to the Crohn's disease, and it may occur without parallel, and it needs a specific therapy plus the treatment of the Crohn's disease. In the eye, we may have episcleritis, which paralyzes the activity. We may have uveitis, which is emergency and needs steroid therapy. We may have cataract from the steroid therapy. And also we may have vitamin E deficiency due to the problems of absorption in the intestine, which leads to keratopathy and night blindness. If we come to the musculoskeletal system, clubbing is a common finding in Crohn's disease more than ulcerative colitis. Okay, if we look to this photo, which was present in the gut in 1971, there are clubbing of the fingers in a patient with Crohn's disease. We may have septic joint. This is catastrophe, in which when there is retroperitoneal extension of the Crohn's disease, there will be development of psoas abscess, which extends to the hip or the acetabulum capsule, and we will have septic hip joint. Also, the sepsis, which is common in patients with Crohn's disease, it may spread hematogenously and causes osteomyelitis. Osteopenia, of course, is common in patients with Crohn's disease, avascular necrosis of the femur. We have said before, it is a common complication of steroids, which are used in the treatment of Crohn's disease. We may have peripheral arthropathy if it affecting less than 5 joints. It is called type 1, and it parallels Crohn's disease. And type 2 is independent of the IBD activity. Okay, the axial arthropathy is not common. Okay, it may be in the form of isolated sarcoiditis or ankylosing spondylitis, and it needs a specific treatment. The hepatic manifestation, of course, the most common hepatic manifestations is Crohn's disease is the occurrence of gallstones due to lack of bile acid absorption in the terminal ileum. We may have transient transaminitis. We may have also primary sclerosing cholangitis. Okay, we come to the kidney, very important topic. Okay, in the kidneys, we may have uric stones. Exactly, we don't know the etiology till now. What is about oxalate stones? The lack of absorption of the bile acids in the terminal ileum makes the absorption of the fatty acid difficult. So there is loss of the fatty acids, which usually combine with the calcium, preventing calcium from absorption. This leads to reciprocal, or there is more absorption of the oxalate. So there will be increased level of oxalate in the body, increased excretion through the kidney. So we will have oxalate stones. Maybe there is ureteric entrapment by the retroperitoneal ligament, and it needs dilatation of the ureter because there will be hydronephrosis. For unknown reasons, there may be benign edema or vulvar edema. Why? We don't know till now. Hematologically, of course, maybe we have hypercoagulability, maybe anemia, iron deficiency, or autoimmune or drug abuse, and systemic amyloidosis. Psychosis. We have said before that there is conflict on the relationship between stress and the occurrence of IBD, but we have said that in a patient who have diagnosis of IBD, the presence of stress is associated with increased activity of the disease and, of course, complication. So patients with active disease, they have anxiety, depression, impaired social interaction, and career progression. Always during the remission, the patient is always afraid of relapse. So any patient with IBD should undergo psychiatric consultation. The differential diagnosis of Crohn's disease. Crohn's disease in 50% of the patient, it affects the terminal ileum. But the terminal ileum pathology may occur with other diseases like tuberculosis, Yersinia, actinomycosis, lymphoma. So there are multiple diseases. So the diagnosis of IBD should be settled after exclusion of the other disease. And another point, if you have no response to the treatment, please revise the diagnosis. In this table, this is the common differential diagnosis we find in patients with Crohn's disease. What is the prognosis of Crohn's? If we remember the definition of Crohn's disease, it is chronic destructive disease. It is chronic destructive disease as the ECG defined it. After 10 years of diagnosis, 33% of the patient will have complex perianal fistula, and the number it increases to 50% after 25 years. If we did surgical removal for the fistula, okay, the recurrence it may occur in a range of 30% to 80% of the patient, chronic destructive aggressive disease. If we come to surgery, for example, you will find that before the era of the biological therapy, 45% of the patient required required abdominal surgery, major abdominal surgery for resection, for obstruction, intra-abdominal abscesses in fistula, anything like this. But after the era of the biological therapy, the number has decreased to 30%. You can say that the number is not significant, but we should remember that many patients who come to your clinic, you begin treating them with steroids and cyprines for years, and this is continuing continue in the destruction. So we begin the biological therapy late. So as we will know in the next lecture, inshallah, we will know that most guidelines now adopt aggressive treatment for Crohn's disease from the start to try to decrease this number to less than 10%. If a patient underwent resection, he may need another resection after the first one. In pre-biological era, you will find that the number is 35%, and here it is 30% because you use your biological therapy in a permanent organ. What is about the recurrence of disease after resection? If we use the clinical parameters, it is 40%, and if we use the endoscopic parameters using Rutgers, you will find that it is 90%. We finished the number one or the first part of our lecture about Crohn's disease. In the next one, inshallah, we will discuss the assessment of the disease activity and the comparison of the different guidelines in the regimen of treatment. Also, we will have some challenging questions and we will try to answer it from the literature, like what is the role of therapeutic drug monitoring, how should we behave with small bowel obstruction in a patient with Crohn's disease, how should we behave with perianal disease, and other questions. I always like to finish my lecture with this dua from our sunnah. اللهم إني أسألك من الخير كله عاجله وآجله ما علمت منه وما لم أعلم وأعوذ بك من الشر كله عاجله وآجله ما علمت منه وما لم أعلم اللهم إني أسألك الجنة وما قرب إليها من قول أو عمل وأعوذ بك من النار وما قرب إليها من قول أو عمل اللهم إني أسألك مما سألك منه محمد صلى الله عليه وسلم وأعوذ بك مما استعاذ منه محمد صلى الله عليه وسلم اللهم ما قضيت لي من قضاء فاجعل عاقبة لي رشدا. بشكر حضراتكم جدا وأعد الله رمضان عليكم دايما بالخير والسعادة إن شاء الله. و thanks a lot. Thank you.